We're going to talk about acute care situations where people's blood sugars can be very high or it can be very low. Those things occur during acute illness or surgery. And we will talk about some more about hypoglycemia, hyperglycemia, which is related to diabetic ketoacidosis, as well as hyperosmolar hyperglycemic syndrome. So during acute illness and surgery, when somebody's having surgery or they're sick or they have an infection, their body is under a lot more stress. When we're under stress, those stress hormones are released, epinephrine, cortisol, all those things that are going to rev things up so we have enough sugar on board. Activates the autonomic nervous system as well. Epinephrine is also part of that. So all of these things work together against the diabetic to raise their blood sugar. So when diabetics are sick or in the hospital, or having surgery, we need to check their blood glucose much more frequently, at least every 4 hours. We need to teach the patient if their blood sugar is greater than 240, then they need to dip their urine for ketones every 3 to 4 hours. And if they have positive ketones in their urine, they need to notify their healthcare provider for some more direction in the management of their care. If they have 2 consecutive glucose levels that are more than 300, or they have moderate or high urine ketone levels, that should also be reported to their healthcare provider. They may need to seek medical care or at least get some direction for management. This involves increasing insulin for patients who have type 1 diabetes to avoid going into diabetic ketoacidosis. Increased glucose for any patient, whether they're diabetic or not. So those patients who are in the hospital for pneumonia and are getting Solu-Medrol, methylprednisolone. Those medications will increase blood sugars for any of us, whether or not we have diabetes or not. So, and when we are hyperglycemic, it reduces the healing, and it also increases the risk of infection because it's got that nice medium with all that sugar in it. So type 2 diabetics, they may have to increase or add subcutaneous insulin to their regimen when they're sick to make sure that they don't go into hyperglycemia. People who are critically ill, vented in ICU or CCU areas, there's a higher target goal for these people. We don't want to drop. They're under so much metabolic demand. They're hypermetabolic. They're all of these things that are going on with them. They like to keep their blood sugar a little bit higher, the goal being 140 to 180. So when the patient is acutely ill, we need to try to encourage them to maintain their normal diet if they're able to do so. They also need to increase non-caloric fluids, and those are things like water, sugar-free Jell-O, and decaffeinated drinks. Really important that we tell them they really need to continue their diabetic medications, even if they're not eating or if they're sick. They just don't seem to understand this, that they think if they're not eating, they shouldn't be taking their insulin, and then they're hyperglycemic, and then they're in DKA, and then they're in the hospital. If they're eating but not as much as they normally do, they need to supplement with carbohydrate-containing fluids, that is low sodium soups, juices, and sugar-sweetened decaffeinated drinks. If they're unable to eat or drink at all, then they need to notify their healthcare provider. Intraoperatively, this is why we really need, when we send our patients to OR, that we communicate with the anesthesiologist or the nurse who comes to get the patient to go to surgery. This patient is a diabetic, so they know. So they will much more frequently monitor their blood glucose levels. It may also have something to do with the type of anesthesia they get, how much anesthesia they get, but they'll know that if the patient is sweating, becomes tremulous, their heart rate goes up, then they know that they need to check their blood sugar because it may have dropped. Of course, the overall goal is to have the patient manage their diabetes as independently as possible. A CDE is a certified diabetes educator, which most diabetics who are newly diagnosed will have an appointment with the CDE, with the dietitian, to let them know, what is going to be their next normal from now on to manage this condition. Evaluating, we want to make sure our patient understands that they can tell us what is the treatment plan, that they can tell us self-care measures they can do to prevent complications, what kind of nutrition they're going to eat, how they're going to manage activity and exercise. Do they have insulin available? And do they know how to store it? Make sure that they're taking good care of their feet. We'll talk about that a little bit later. And implement measures to increase peripheral circulation. Sometimes that's going to be knee-high stockings, TED hose. Going back to the feet, they need to wear nice, comfortable shoes. And if they get new shoes, they should not wear them put them on and wear them for 8 hours. They need to break them in, because if they have neuropathies in their feet, they're not going to realize that they have an injury to their foot. So acute complications of diabetes, we talked about, already listed those. And we talked about hypoglycemia already. Get to that page. So these are the symptoms that happens when your blood sugar is less than 70. These symptoms too also resemble acute alcohol intoxication. So, and usually if anybody's a paramedic or an EMS, most of the time if they find anybody who is unresponsive or they're lethargic, or they think they may be impaired in some way, they go ahead and check their blood sugar, because a lot of times that's the problem. The blood sugar is too high, the blood sugar is too low. Some causes of hypoglycemia, the majority of the time it's the mismatch of the timing between food intake and the peak time of their insulin or the peak time of their oral medications. Other things, taking alcohol and without food. If they don't eat enough food and they have too much of their medicine or insulin on board, too many diabetes meds, they exercise without eating, they're doing something at the different time during the day, it gets their rhythm all out. If they've lost a lot of weight without medication adjustment, or those patients who are using beta blockers. Maybe they have heart failure, or they have had an MI in the past, or they're using it to manage their hypertension. Beta blockers will mask the signs and symptoms of hypoglycemia. So we need to be aware of that. Those are the OLA medications. Sometimes if also the patient can have symptoms of hypoglycemia if we drop their blood sugar or they've dropped their blood sugar too quickly. Something as simple as 180 to 130. That could be something that causes a sudden metabolic shift in them, and they will feel the symptoms of hypoglycemia. Hypoglycemia happens much more quickly, a rapid onset, than hyperglycemia. When the blood sugar drops to less than 70, those counter-regulatory hormones are released, and its job is to increase the blood sugar, right? So that also shuts down the production of glucagon, and decreases insulin secretion. So epinephrine is activated. So epinephrine is responsible for those symptoms of being shaky, heart palpitations, being nervous, being diaphoretic or sweaty. Also anxiety, hunger, and pallor. And the pallor comes from shunting the blood that is necessary to those core organs. There's also a phenomenon called hypoglycemia unawareness. And this can happen when what happens is the body cannot warn the patient that their blood sugar is dropping or that it is critically low. Risks that cause this, many episodes of hypoglycemia in the past. The elderly is more common, and again, people who take beta blockers because they mask the symptoms of their hypoglycemia. So treatment is the rule of 5. You can see that in table 4819 in your book. We should teach them to eat or drink 15 grams of a rapid-acting carbohydrate. If they're conscious, that could be 4 ounces of regular soda or 5 to 8 lifesavers. A teaspoon of syrup, or a tablespoon of syrup, or a tablespoon of honey. Could be 4 teaspoons of jelly, or 4 to 6 ounces of orange juice. After we do that, we wait 15 minutes and check the sugar. If it's less than 70, we get them to repeat that, eat another 15 grams of carbs. If they're stable, blood sugar is greater than 70, then we will order their next tray and we give them a carbohydrate and a protein snack, which typically can be peanut butter crackers and milk, could be graham crackers and milk. If the sugar remains low 2 to 3 times, then we need to notify the healthcare provider. If they are unconscious or unresponsive, then they're going to get IV D50, which is 50% dextrose, and the dose for that is usually 20 to 50 milliliters, or we're going to give them IM glucagon. Preventative things we can teach them to avoid is finding a ritual, finding a schedule for this, taking their meds on time, coordinating their meds with their meals, getting enough food to eat, or carrying a snack with them when they're exercising, because remember, as they exercise, those muscles are intaking that glucose, and that can make them hypoglycemic too. Teaching the family and the caregivers about the signs and the symptoms. A lot of diabetics now, I have seen that they're getting diabetic tattooed on their wrist or on their arm. So anybody that comes upon them and they're unconscious can get them the right care right away. They need to carry simple carbohydrates with them, whether that's lifesavers, candy, hard candy, anything that they can pop into their mouth quickly, and wear or carry a diabetes ID. Hyperglycemia, these are the signs and symptoms of that. You see the 3 Ps. They have a lot more abdominal pain and cramping and nausea and vomiting when the blood sugar is high. Hyperglycemia can mean that the patient is progressing to DKA or to hyperosmolar hyperglycemic syndrome. Causes, again, illness, infection, steroids, eating too much. Maybe they need an adjustment on their diabetes meds. Maybe they're not taking their diabetes meds. They're very sedentary. They've had an inordinate amount of stress in their lives lately. Or they're using a site or that's not easily absorbing the insulin, or maybe their insulin is not any good. More gradual onset. We get a little more symptoms, a little more slowly when the patient is hyperglycemic. Treatment, get medical care, of course. We're going to try to bring their blood sugars down, but not too quickly. For home care, check those blood glucose and urine ketones every 4 hours. We would even do that in the hospital. We don't typically check ketones, but we do, of course, check our blood sugars. You know, you can increase that every 2 hours, every 4 hours, using clinical judgment if you think that's necessary. We need to try to encourage them to drink fluids hourly, because hyperglycemia produces polyuria. You have all that sugar in that urine, and that sugar is an osmotic diuretic. So as their urine is very sweet, then that's going to cause much more voluminous urine, and they're going to get dehydrated. So we need to encourage them to drink fluids hourly, or we need to get them a maintenance IV fluid to protect them from doing that. Other preventative things are listed here. Following sick day rules. So these are sick day rules. They need to be encouraged to continue taking their medications and insulin in spite of whether or not they're eating. Check their blood sugar every 4 hours. Check ketones every 4 hours. Increase those calorie-free fluids so they don't get dehydrated. And they should also be taught to, or we would check their temperature much more frequently. Maybe instead of every 8, we would have our PCT check it every 4, because they may have an insidious infection going on that we really haven't seen that yet.